So we invite now Daniela Fodor from Romania, Cluj-Napoca. You know her already. And she will present the ultrasonography in the differential diagnosis of musculoskeletal inflammation.
Good afternoon. Why I choose this presentation? Because in fact it's difficult to say when we have inflammation or not. Generally, especially for rheumatologists, when in a lesion, in irrelevant lesion, there is a vessel, there is a pixel of color. For a rheumatologist, it means inflammation. But in fact, you will see we don't need all the times color Doppler, and not all the color pixel are inflammation. I have no conflict of interest. I will try to answer this question, when ultrasound findings can be considered as inflammation or not, how to recognize the findings as real inflammation, and which of the ultrasound findings are the results of an inflammatory process. In fact, when we have a patient with a painful or swollen part of the body, it's very useful to start with some history, some clinical examination, to have few laboratory data. That will be very, very important for our judgment. And then we'll do ultrasound. What we are looking for? First, from fluid, I mean effusion in joint, in tendon sheet, in bursa. Then look about synovial hypertrophy, and finally, only finally, about Doppler signal. Talking about fluid, we can split the two aspects of the fluid as anechoic or non-anechoic. If the fluid is anechoic, we can think to the degenerative pathology, post-trauma, mechanical irritation, or inflammatory process. Talking about a non-anechoic fluid, we can find an hypoechoic aspect, or this other dyshomogeneity, hyperechoic spot, or even fibrin septa. But all these are the same etiology. For example, this patient, it was a woman, 56 years, come with a swollen knee, and at ultrasonography in the suprapatellar scan, you see there is a fluid, there is an effusion inside the joint, and for sure this is an anechoic fluid. And we have to think, what has this patient? Has this patient an inflammatory process or not? If we found something in history, or if we think that could be a trauma, move the transducer along the medial collateral ligament, maybe you will find a tear. Look at the medial meniscus, maybe you'll find a tear, and you will conclude that this modification are post-trauma, and there is no inflammatory process inside the joint. If you think that this could be osteoarthritis, and that's an inflammatory process secondary to osteoarthritis, look at the medial meniscus, see if there are degeneration, if there are osteophytes, and don't forget to look at the hyaline cartilage, and if there are some modification you already see in the Plamen presentation, you can say it is an osteoarthritis for sure, and this is a secondary process. But if you think that this is a real inflammatory process, and it's the large joint part of rheumatoid arthritis, move the transducer to the special joints in which you know that the inflammatory process can appear. For example, look here at the MCP joint. A lot of proliferated synovia, a lot of Doppler color, this is a real arthritis, and it's a very active arthritis. And also to the wrist, you see the same proliferated synovia and hypervascularized, very, very active arthritis in the radiocarpal and in the intercarpal joint. If you think that this collection, this fluid in the joint belongs to spondylarthritis, look at the special places in which the special findings related to the spondylarthritis could appear. And this is, of course, enthesis. In this case, we are at the Achilles tendon enthesis, and you can see a huge and hypervascularized erosion, along with the other modification or the other findings that characterize the spondylarthritis. But if the fluid is non-anechoic, we have some problems. Because, for example, this Baker cyst. This Baker cyst is non-anechoic, has a hyperechoic spot, has septa, has proliferated synovia. Most probably is inflammatory. But without some history and without synovial fluid analysis, we'll never know. Even blood inside the cyst can give this appearance, as Christian already showed us. So, my advice is to make a puncture, see how is macroscopical the fluid, then send the fluid to laboratory, and you will find very well if this is a real inflammatory process or not. Let's give some example. We are also on the knee in longitudinal scan. There is a fluid. For sure, this is this homogeneous fluid. There are some hypoechoic spots that are moving when I press with the transducer. There are also a little bit of proliferated synovia. Here it's hyperechoic, but this is related to the presence of fluid in the anterior part of this proliferated synovia. What I did, of course, I made a puncture, and look what I have. I had a clear synovial fluid, and of course I asked myself why this clear fluid, serochitin fluid, has this ultrasound aspect. Because this was a fluid from reactive arthritis, and here we have a lot of inflammatory cells and other components that give us this homogeneous aspect of the joint fluid. Let's see another case, quite similar. This homogeneous seems to be some septa. Let's start the movie. Indeed, this is fluid. This is fluid. Quite homogeneous, but this hypoechoic aspect and septa are very important. Of course, a puncture. This was blood. And of course, I already knew from the history previous taken from patient before ultrasound that it was a trauma, and this was hemarthrosis, and this fluid is not inflammatory despite this aspect. We are also in the knee, hyperechoic spot, maybe some proliferated synovia. We'll see when the movie will start. Many hyperechoic spots. You see like a storm, snow storm. Once again, hyperechoic spot. I punctured. I obtained this fluid. When you see it, the first view, you think that could be septic arthritis. In fact, when I see this kind of fluid, of course related to the patient history, I don't think to septic arthritis. I think to gouty arthritis. How was in this case? Let's see other hyperechoic spots. You see, all are similar. And all are moving when you press with the transducer. let's start the movie. We are also in the knee. I press with the transducer. You see these hyperechoic spots, some septa, some proliferated synovia. Nothing special, or all the same. Let's see what I obtained. I obtained this fluid, and I already told you that when I see this fluid, I don't think to septic arthritis, but I think to microcrystalline arthritis. And this case was a case with crystal pyrophosphate arthritis. In this case, the patient came with important pain and swollen elbow. I made an ultrasound, the same, this homogeneous fluid, also hyperechoic spot. I pressed with the transducer, but not many movement inside the joint, and this was related to the high pressure of the collection in this joint. This is, in fact, the posterior recess of the elbow. I put a needle inside and look at the fluid. Now, when I see this kind of fluid, I think to the septic arthritis, and this was, in this case, was a septic elbow, and the bacteria was Staphylococcus aureus. So to conclude, the presence of this hyperechoic spot are very important, but don't bring us many elements for diagnosis. Look at the patient, look at the clinical history, and don't forget to look at the synovial fluid. But we have spot not only in the joint to look at this tenosynovitis. It was flexor radialis carpi. This homogeneous content and many spots. Even in my gel there were spots, but these were not pathological. So fluid, a lot of fluid, and with hyperechoic spot. But look at this aspect. It is inflammatory sign for sure, but you cannot say much than this. This is inflammation. It's red, it's warm, that's all. I introduce a needle inside this tendon sheet. I aspirate it, and let's see. Of course, this is septic. It was a septic tenosynovitis. The septic tenovitis are very rare. I have only 2 or 3 cases proven to be septic tenovitis, and excepting this case, the other one had other disease. One was diabetic, and the other one had hepatic cirrhosis. Talking about synovial hypertrophy, the definition of synovial hypertrophy established by Omeract was already said today. It's important, and when we find it, of course, we have to verify the presence of vascularization. We are also in the knee, in the lateral recess. There are fluid, I see it's an echoic fluid, but look, all of this solid part, solid mass, that are attached of the capsule of the joint, all are proliferated synovia. In this case, this is a particular aspect of velonodular proliferated synovia, and you see that there are not little bit compressible and not displaceable. They are in the same place when I press with the transducer. For the large joint, generally we don't have Doppler signal. Using color or power, not important. But sometimes we can find, and I like it very much, this proliferated synovia attached to the capsule. In fact, the place the it comes, and look how the blood comes from the periphery in this synovial nodule. You cannot say about diagnosis, only see that there is fluid, there is synovial hypertrophy, there is vascularization. You can say, yes, this is an inflammatory process, but nothing about final diagnosing using only this element. So, for example, this case was knee osteoarthritis. We are used that in osteoarthritis to have only fluid and the degenerative process, the meniscus, bone, hyaline cartilage, but especially in the large joint, we have frequently proliferated the synovia. You see how much was proliferated synovia in this knee? And generally, these cases are very difficult to be managed, and the treatment we have to have imagination to treat these patients. But in previous case, it was no vascularization. In this case, it was a case with spondyloarthritis. We have the same things: septa, synovia, fluid, and in this case, other case with spondyloarthritis, part of synovia was highly vascularized. I can assure you that from clinical point of view, there are no huge difference between these two patients related to the local pathological process. The patient had pain and had problems during moving the knee. Concerning the wrist arthritis, I'll already show you the inflammation here, the proliferated synovia and the high vascularization, and I already show you the MCP arthritis. In this case, is the presence of inflammation. It's very easy to be interpreted. But sometimes we don't have Doppler signal inside the joint or inside the tendon sheet, but we have this situation. We have this an MMC metacarpophalangeal joint. You already saw the extensor tendon. And look at this region in which there is a huge vascularization. In fact, this was a case of paratendonitis specific for psoriatic arthritis. There is inflammation. There is inflammation near the tendon, in the structure, in the vicinity of the tendon, but there is an inflammatory process. But let's see this case. This case was a man comes to us with this huge knee. Look at this panoramic view, a lot of fluid, a lot of proliferated synovia, and look what nice is this proliferated synovia in this detail, and very, very vascularized process. What I did, because it seems to be inflammatory, yes, everything is here, but I had no diagnosis of systemic disease. So first I aspirated the joint, I obtained this sanguinolent fluid, and finally I performed a synovial biopsy, and the surprise was that in this case I have a case with pigmented villonodular synovitis, so no inflammation despite of the ultrasound aspect. But turning to the patient history, the patient had no pain on this joint. A little bit problem during walking, but no pain and no inflammatory sign in this joint. Don't forget about artifacts. There are some special artifacts. For example, these twinkling artifacts related to orthopedic device. We have in musculoskeletal ultrasonography a lot of orthopedic device, or this twinkling artifact in power Doppler related to the thread. It was a post-operative patient. Don't interpret this image like an abscess. And this is the classical image, and in the floor there are some people that were to us in Cluj, and they have to examine and to characterize this image, and I asked them, what is this? What is this? And all, no, not all. Many of my students answer, a vessel, a vessel, a vessel. In fact, this is an artifact. And this is an artifact in a patient with rheumatoid arthritis with active inflammatory wrist, so it's easy to interpret this image like a vessel. But of course, there is an artifact. To conclude, I come to this letter to the editor published a few years ago that I like it very much. Richard Wakefield from Leeds, a very, very nice person, had a patient and found some hyperechoic spot inside the Baker cyst, and said these for sure are microcrystals. But he proved that there was a gas bubble related to vacuum process from NIM, a very nice explication. And I liked very much the title of this letter, All That Glimmers Is Not Gold. So I tell you, not everything that is a fusion or color signal, it's inflammation. And to say that the process, it's an inflammatory one, make correlation with clinical and laboratory data. Thank you.
Thank you very much. Are there any questions? I didn't get the man with the big swollen knee. What was it?
Farmer worker.
What was it?
Farmer worker. Farmer.
Okay. Yeah. Okay, thank you very much.